السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم. In case of the week 17 on our channel 4D Passion, this is a case referred to my center for early third trimester anomaly scan. First, you will notice that there is increased nuchal fold thickness. Here is about 10 millimeter in thickness. It should not exceed 6 millimeter in thickness at this age. You will notice here also widened interhemispheric fissure with multiple lines at the interhemispheric fissure, as well as colpocephaly with the widened lateral cerebral ventricle and tapered anterior horn. The cavum septum pellucidum is missing right here. It should be box-shaped or rather triangular, but missing here. And you will notice the dilated lateral cerebral ventricle. Also, you will notice dilated third ventricle that should look like slit-like. Instead, it is markedly dilated right here. The cerebellum was unremarkable at lower normal, part of being a lower normal biometry for gestational age. You will notice again the widened interhemispheric fissure with multiple lines. All the aforementioned findings are in favor of agenesis of the corpus callosum, at least partial. Here is a choroid plexus cyst, and another on the contralateral side. You will notice here also the colpocephaly. There was hydronephrosis affecting both right and left kidneys. Again. With markedly thinned renal parenchyma on right side and markedly dilated renal pelvis that's about 48 millimeter in diameter. The left kidney also had back pressure, but rather moderate, with preserved myometrial thickness about 8 millimeter in thickness right here, with a pelvis diameter of about 13 millimeter. Here's again the marked back pressure. The bladder was adequately filled. The biometry of the fetus was about 27 weeks plus 2 days gestational age at 36th percentile for age. And you will notice here that the abdominal circumference is enlarged by the hydronephrosis, and the femur length is rather shortened for gestational age, moderately shortened. You will also notice hypertelorism. Roughly, the space between both eyes should handle one orbit, but here you can put two orbits frankly, and you will notice they will suffice to fill in this space. Well, you will also notice prefrontal edema of about 8 millimeter in thickness. And here you will notice that there is a ventricular septal defect. If you watch carefully, you will notice a ventricular septal defect. And here it was an outlet VSD with aortic overriding perimembranous outlet. And you will notice that the aorta is seen overriding the VSD and communicating with both right and left ventricles. Also was noted ARSA aberrant right subclavian artery. Again, the aorta overlying the VSD. And here is on color Doppler. You will notice that there is a VSD and the aorta receiving blood from both ventricles. The amniotic fluid was a normal amount. And here is the lateral, brain findings: dilated third ventricle, dilated lateral cerebral ventricle, choroid plexus cyst. Here, dilated third ventricle. So the findings are missing cavum septum pellucidum with dilated third and lateral cerebral ventricles, and the colpocephaly and widened interhemispheric fissure. These are signs of agenesis of corpus callosum with bilateral choroid plexus cyst, mild prefrontal edema with thickened nuchal fold, hypertelorism, subaortic outlet VSD with malalignment, aberrant right subclavian artery, and bilateral hydronephrosis marked with parenchymal thinning on right kidney and moderate on left kidney. The main diagnosis is trisomy 18, considering presence of choroid plexus cyst, agenesis of corpus callosum, malalignment VSD, and ARSA. The main differential diagnosis is trisomy 18. Trisomy 18 incidence is 1 per 6,000 at birth. Male to female ratio is 0.65. Etiology: free trisomy of chromosome 18 is found in more than 99% of cases, rarely mosaicism or structural anomalies involving chromosome 18. The sonographic findings are either in CNS with neural tube defects, agenesis of the corpus callosum like in our case, and posterior fossa anomalies. Micrognathia of variable severity associated with 50 to 70% of cases. Congenital heart disease, septation, conotruncal malformations, and polyvalvular disease. Abdominal wall anomalies such as exomphalus, urinary tract anomalies such as cystic renal dysplasia and horseshoe kidney, cystic hygroma, and skeletal anomalies such as micrognathia, clenched hands with overlapping fingers, and aplasia radii, and rocker bottom feet. Fetal growth restriction of early onset also. Soft markers described in association with trisomy 18 are nuchal abnormalities with enlarged nuchal translucency, strawberry-shaped skull, and choroid plexus cysts. The differential diagnosis look for trisomy 13, which has fetal growth restriction, hollow prosencephaly, microphthalmia, and congenital heart disease, and bilateral cleft lip and palate. Triploidy look for fetal growth restriction very early, that plus posterior fossa anomalies, plus macrophthalmia, plus oligohydramnios. And the fetal akinesia deformation sequence look for fetal growth restriction, micrognathia, diffuse joint contractures. The differential diagnosis. This includes other chromosomal anomalies characterized by multiple malformations in the early FGR, as well as group of neuroarthrogryposis, such as trisomy 13 and triploidy and fetal akinesia deformation sequence. Prognosis, survival, and quality of life. Trisomy 18 is a lethal condition in most cases. Of the relatively few live-borns, 90% die within 6 months, and less than 5% of cases reach 12 months of life. In the survivors, severe mental retardation is constantly associated. Significant hearing and sight impairment is frequent, and the growth is severely compromised. In addition to the major anomalies, another determinant of mortality and morbidity is the predisposition to infections. The recurrence risk is empirically estimated to compromise 1% of all autosomal trisomies. Take-home message: having choroid plexus cyst, ARSA, agenesis of corpus callosum, and malalignment VSD, you are in the way of trisomy 18. Chromosomal anomalies have soft markers and multiple anomalies that usually make them differentiated from other non-chromosomal syndromes. Soft markers are additive and supportive for diagnosis. A good anomaly scan will greatly aid the genetist in counseling the mother. In this case, for example, just a karyotyping will confirm diagnosis, and the mother could then be assured that the recurrence risk is only 1%. Kind regards, and see you soon. دكتور عمرو فاروق، عمرو سكان درنجات بحيرة. السلام عليكم ورحمة الله وبركاته.